Good afternoon. Thank you so much for joining us today. It is my pleasure to introduce Michele Bolles. Michele currently serves as the National Executive Vice President, Quality Outcomes, I can't read, Research and Analytics at the American Heart Association. In this role, Michele leads the team to provide resources, implement guidelines, conduct research, and cultivate global transformational relationships for the delivery of quality health care. The AHA is the nation's oldest and largest voluntary organization devoted to fighting cardiovascular diseases and stroke. The AHA funds innovative research, fights for stronger public health policies, and provides life-saving tools and information to save and improve lives. Michele holds a Bachelor of Science degree in Public Health from Westchester University in Westchester, Pennsylvania, and she has earned certifications as a Certified Health Education Specialist and a Master Certified Health Education Specialist from the National Commission of Health Education Credentialing, Inc. Michele resides in Phoenixville, Pennsylvania. Michele?
Good afternoon. I'm really happy, excited to be here, and the lights are really bright, sorry. As you heard, my name is Michele Bolles, and I am the National Executive Vice President for the American Heart Association. And I have the great opportunity to have been with the organization 32 years. So I try to tell people I started when I was 15, but no one ever seems to believe me about that. But when we think about the Heart Association, many people don't know we're actually coming upon our 100-year birthday. So we will be celebrating our 100-year anniversary in 2024. And so having been in the organization almost a third of the time that they've been in existence, I feel really fortunate, and I've seen a lot of evolution along the way. You know, we've changed our mission over the years, and we've tweaked that, and now our mission is to be a relentless force for a world of longer, healthier lives. Got that right, yeah. And so one thing that people use to describe me personally is the word relentless, and I'll talk a little bit about how and why I think this opportunity that I'm here to share. I'm looking for the advancer. Okay, here it is. Opportunity to share some great information with all of you today. So as we think about the organization, we have about 3,000 employees. We're 40 million volunteers across the country. And certainly being the American Heart Association, we're actually a global organization. I don't know that others know that. But we, personally, we have quality improvement programs that I get to lead in about 13 other countries. And then our CPR and science works in over 100 offices and work in about 100 countries. So very exciting opportunity for us to be here today. How do I advance this? Okay, so enough of that, right? Why am I here? So what we're here today to talk about is how the American Heart Association has really, doubled down on the commitment to health equity. We really know that the rural communities have been so critically important in the chain of survival and what needs to happen across the country in providing the right patient, getting the right care at the right time. And as Deming says, variation is the enemy of quality, right? So anytime that we can ensure that there's very few variations in care and that every patient is getting the right care, we want to do everything that we can to ensure that. And we do that through a lot of things. We start with our research, and our foundation is really based in science. We write most of the treatment guidelines, as you know. We partner with other organizations as well. We also do we come out with statements. We have a statement on a rural paper, presidential advisory that we'll talk about in a few moments, having to do with sort of why the AHA is doubling down in this space and why we have some great opportunities to collaborate with NRHA and all of you in this room. So, but before I get started on that, we also in 2020 established what we call our 10 commitments to health equity. And number 6 actually is, I'm not going to go through all of them because we would need another hour for that, but really wanting to look at how we can remove the barriers for health equity and improve access to care and quality of care. And so everything that we do is really, that keeps us with our true north of the work in the programmatic areas that we're delivering to all of you. So when we think about rural, obviously I'm preaching to the choir here, right? But when you think about that 20% of the population is in the rural space, yet I think I read that it covers the rural areas, 75% of the US is considered rural communities, but only 20% of the people. We know that it's generally an older population, and we know that diversity is growing in certain parts of the country, but it's generally a white population across most of the areas of rural communities. We know that, I got ahead of myself on the slide. But as you think about the parts of the country, we look at the map and we say, where can we make the most impact with the programs that we have? And the organization really stepped into the space in a big way. And we're now focusing not just on, the cardiovascular risk factors, certainly, but we're looking at maternal and child health and mortality rates, really looking at access to care, and then risk factor management and social determinants are so important. So as we moved through and the organization started to look at the data, and we started to see where all populations were reducing risk, but then we started to see that divergence, right? And the rural communities were not faring as well as their urban or suburban counterparts. The AHA really needed to lean in, and we wrote a white paper. It was Call to Action. It was published in February of 2020, and we all know what happened a month later, right? So we were really going to move forward with a lot of work in the rural space, and then COVID sort of derailed some of that. And so the great news is, as we managed what we were doing around COVID, all of you and all the challenges that you have to deal with in your communities, in your hospitals, and the resources, staffing, the AHA was trying to work side by side with you on the COVID stuff, but we also were behind the scenes trying to figure out how we could attack the rural challenges. And with this data, we then set forward with a group of key opinion leaders, our great staff that we have, and we dove into assessing what might the AHA do, right? So with the paper, it really called out 3 primary issues. We know that we have to increase access to care, and with rural hospitals closing and the way that where people live compared to where they can access health care, there's certainly needs for other challenges and other telehealth and other ways to receive health care. We wanted to look at how we can improve the quality of health care, and that's where our registries and the program I'm here to talk about today are, and certainly addressing the risk factors and the social determinants. So as we think about barriers to access, we know that nearly 1 in 5 Americans live in the rural areas and need their local hospitals. And we're trying to figure out the best ways to create systems of care so that every patient can access the care that they need. And the paper really focused on ways that quality of care is important and how we can address workforce shortages, and certainly looking at the quality metrics that are important for rural hospitals. And what we know about this space is it's not a one-size-fits-all, right? So the AHA, how many of you have heard about Get With the Guidelines? Any people? Okay. So Get With the Guidelines are registries that we use in all the hospitals across the country. But a lot of times they were developed for a one-size-fits-all, and we had to go back and look at them in a more detailed way, and we'll talk about those details in a minute, because for a long time, the critical access, the smaller rural hospitals, were sort of a footnote in the work that we were doing. I'll acknowledge it, and I'll tell you, it's a personal passion for me. In the communities that I worked in the Appalachian region for about 15 years with the Heart Association in my role when I covered Pennsylvania, Delaware, Kentucky, West Virginia, and Ohio. And I would go into those communities, and I learned so much about how unique and the challenges were so different in those communities. We also know about the risk factors, certainly, that impact health. There's literacy rates, there's higher rates of hypertension, diabetes, obesity, and then certainly looking at food insecurity. We know about underinsured employment, all of those social determinants that come into play. So the AHA is really trying to actually address those types of issues as well in our plan. Our rural strategies really bucket into those three areas I just mentioned. So we have increasing access to care, improving healthcare quality, and how do we address risk factors. And all of it, again, is based on the science of the Heart Association. I could, when we were putting together this presentation, I could stand up here and cite guidelines and, treatments and papers and research, but you can all read that on your own, right? So what you want to hear from me is, well, what are you actually doing? What is the Heart Association actually doing to help our hospitals, our communities, so that we can create a culture of health that is going to promote longer, healthier lives? We certainly are always working in the public policy space. We're really, focused in on, right now, laser focused on telehealth, maternal health, and Medicaid expansion. Certainly understanding those workforce issues and how we might be able to, we, the organization, may be able to help all of you. With improving quality of care, we'll talk more about Get With the Guidelines and our systems of care work. And certainly hypertension is the single most, factor that we think we can impact, positively impact. We're working with a lot of federally qualified health centers, clinics, and trying to really, in the community setting, improve hypertension control. We're working closely with the AMA on that project. And then addressing the risk factors and we know that in certain parts of the country, if not everywhere, we still have to worry about tobacco use, and we have what the Heart Association entitled a Social Impact Fund and a program called HeartCore, which I'll explain in a moment. And then we have a health equity research network that's focused on simply trying to uncover and unlock the ways in which we can improve care and eliminate disparities. So in the public policy space, we really have worked to help with Medicaid expansion, looking to expand postpartum care coverage and telehealth coverage. And we're doing a lot of work around telehealth and how we can actually certify and work with facilities, because we were all thrown into it during COVID, right? A lot of hospitals, a lot of clinics knew they had to turn it on and start using it, but they didn't really know what they were doing. Many of the sites were sort of building the ship as they were sailing it. We have a Doctors with Heart pilot, and so last night I had the opportunity, I had to spend some time with Brock Slaybach, Michelle Raithman, Leslie Marsh, and Tommy Barnhart, and some of my HA colleagues. And I had an opportunity to just sit around, and we were talking about some of the challenges, the things that were happening. And one of the things I heard is, and I knew, but it was interesting to hear it again last evening as I was sort of fine-tuning my remarks for today, was about, telehealth and specialists, right? Having the access to specialists and those that may see the more unique, physicians that may see more unique challenges. So the AHA has actually created a program called Doctors with Heart, and we're piloting that right now in, you can see where we're piloting here, but parts of Ohio and Wisconsin, and we're actually looking to explore it into the Dakotas. But that program is really a peer-to-peer program to connect cardiology specialists with the local physicians and cardiologists in their communities that might need to, bounce an idea, talk about a patient that may be, of course, HIPAA compliantly, but talk about a patient and how, what the challenge might be, or what other services or differential diagnoses they may be needing to look at with that patient. So that is a program we're doing. We're really excited about it, and we think that it will grow across the country, but we are piloting it right now in these communities. Wanted to share that because what we're trying to do is create different ways to get everyone access to those specialists as they need it. HeartCore, super excited to announce this. We received almost $9 million grant where we are working with, we're going to have 100 HeartCore members that will be trained and working in 50 communities over 3 years. And they're really out there to, again, hypertension control, blood pressure detection for hypertension, working with clinics, and certainly addressing nutritional security and insecurity, and reducing tobacco use among youth. Certainly we know that vaping has become its own public health problem at this point. Another program we're doing is around controlling blood pressure. We actually received a grant from the HRSA. So it was a HRSA grant, and we are in about 350 sites that we're doing a intensive quality improvement program for outpatient hypertension control. And 16% of them are rural, so it's not a huge footprint in the rural space, acknowledging that, but it will be the model that we're developing that will be able to be then spread to all the other federally qualified health centers across the country. We're very excited to have the opportunity and the insights that we're learning about staffing, turnover, resources, training. Sometimes it's documentation, sometimes it's training. You know, what are all the issues related to why the adherence issues with the patient, being prescribed the right medication, can they afford it, what are the access issues? So, and then we think about the outcomes, right? Improving outcomes. And then that's sort of where the rubber meets the road for why the bulk of what I'm going to talk about today with respect to this program. But before I jump into it, I think it's really important to note, you know, I mentioned that I went to dinner last evening, and we talked about, you know, why we were here and what is our affinity to rural health. And as we went around the table, everyone was talking about, well, I went to high school, it had 9 people? Graduated in a class of 9, and someone else said 36, and almost everybody at the table were living and either lived and or worked in rural communities. And I was sitting there, in my head I was saying, now it's 32 years of cardiovascular experience in public health, and in my head I was thinking, oh my gosh, am I going to say out loud that I went to a high school with 305 students in downtown Philadelphia? You know, I'm a city slicker. Do I belong here? You know, so I started to have this little conversation with myself, and you know, I started to share what I've seen and what I've learned over the years, and so yes, okay, I'll admit, maybe I am a city slicker, but when I think about cardiovascular disease, and when I think about rural health, there's 2 reasons why personally I am extremely passionate about both of those things. So first, on the cardiovascular front, excuse me, 1979, I don't know, maybe I was 12, 13, I don't know exactly how old I was, but I grew up in the city in a row homes, sandwiched between 6 households of family, very tight-knit Italian community. My grandmother bought everybody houses and made them all live on the same street because she didn't want anybody to move away. And so we heard the scream. We were having dinner, we heard the scream. We ran outside, and my uncle, who had his head under the hood of his car, fell down, had a heart attack. And I remember somebody pounding on his chest. I remember 79. I don't know who knew CPR or what that was about, but somebody was trying to do something. And I remember him being purple and the ambulance coming, and he died. I watched him die. And honestly, I remember thinking about it, like, why isn't anyone talking about this? You know, this kid witnessed this tragedy, but it was never really discussed. We had his funeral, it went on, and that was sort of it. And, you know, I've always thought, like, through my high school, college, you know, that was such a weird experience for me. And I knew I wanted to go into healthcare, right? So I moved into the Heart Association, and I've worked here for as long as I can remember, as I said. And in 2007, I got a phone call at work that was one you never want to get. It was my mother saying, hurry to the hospital, your father's in cardiac arrest. So went down to, I don't know if those of you know, Hahnemann University Hospital. It used to be open. It was in downtown Philadelphia, a good medical school. It's now since closed. As the trend with the rest of the country, hospitals are closing where we need them. But he was, had been at work, had chest pain, sweating, told his coworkers, no one did anything. He walked to his car. He walked down 4 flights of steps, walked to his car that was parked across the street from Hahnemann University Hospital's emergency room. He got in his car and tried to drive home, and he died behind the wheel of his car. And in Center City, Philadelphia, kind of in the shadow of the Art Museum, or also known as the Rocky Steps, you know, he passed away. And my brother's a first responder, and I work for the Heart Association, and we couldn't save this man, right? And so CVD health is extremely important to me. It's personal for me. And so I tell you that story not to sort of, you know, suck the air out of the room, but the system of care, the public health, the risk factors, it all comes together, and if we can't make that change and work with the communities that we're in, that's our mission. At the Heart Association, I know that's why you all are sitting in the seats that you sit in, to improve care, save lives. So I tell that because CVD is so personal for me. The second part of that I had to talk myself out of last night when I was thinking I didn't belong here was I did cover the Appalachian. I've had 2 schools of thoughts on the way to pronounce that. So if anyone wants to school me after, please do. That, going into those hospitals and going into those communities and thinking about things that I never had to think about before, like weather, terrain, how's an ambulance coming over the mountains? And we did a program called Gap in the Mountains in West Virginia eons ago. But all of those things I learned, and going into hospitals in small communities in Eastern Kentucky or West Virginia and walking through and saying to me, we can't get our stroke patient in 3 hours. We can't get TPA administered. We can't get a patient through here in 3 hours. And walking through the hallways and walking in one room and the clock's saying 10:05 and walking in the next room and there's no clock, so someone's using their watch at the time and it was, 10:27. So you're losing time in every room you go in. And so when we started to sort of double click on what the root cause was, they realized that they didn't have an atomic clock system. The clocks weren't synced. And we started talking about that. And one of the quality people said to me, we can't keep clocks in the hospital. People steal them. And I was thinking, people steal clocks? Like, why are they stealing clocks? And she's like, people don't have wall clocks in their homes. They may not be able to afford them. So their family members take them out of the hospital. And I thought that was such an eye-opening thing for me. So simply because that was something I had never thought about in working in urban environments or suburban environments. And it was like eye-opening that there's a whole different set of things that I have to think about when I work in the rural space. And so we started to really put the rural hospitals, the critical access hospitals on the map at the Heart Association. And having the opportunity to be in a leadership role, I was able to help push and push. And so recently, we started to look at this rule paper. The timing was perfect. We were able to get a almost $4 million investment from the Heart Association, internal money, not a funder. AHA put up their own funding to this project specifically to help us have an initiative to simply focus on rural health. And so, long story short on that one, but we have this opportunity to really modify our recognition program that we'll talk about in a second. And so it's super exciting to be involved in this. Some of the other systems of care work that we do is funded by the Helmsley Charitable Trust. So you'll see here a map of states that we've had the fortunate benefit of getting funding to do work. So if you're in any of these states, there's opportunities to participate in some of the Mission Lifeline work that we do. Mission Lifeline is our code word for cardiac systems of care and stroke systems of care. So that is sort of the work that we've done. It's mostly STEMI care and stroke care. So, we're launching this rural initiative and we are here to talk about it. So as we think about the journey and translating science, we're a science organization, we're a guidelines writing organization. We're very different from the rest of other organizations around the country in that we're a scientific organization, we're a specialty society, we're an advocacy organization, community health, and a quality improvement, right? Some organizations, other sister societies of the Heart Association are one of those things. We are all of those things. And so we have this opportunity to work in all different dimensions of healthcare. And so from guidelines to research to looking at how we take the data from our registries and use it for real world feedback and looking at it to give feedback to EMS so they understand where to bring the patients. Are the patients getting the proper care? Do they need to go to a different facility? Empowering those pre-hospital staff to be able to make the call and say, hey, I'm bringing in a STEMI, be ready. All the pieces that have to happen in play to save that person's life and to timing everything. So, and then we use that data for programs like having to do award and recognition programs. We have this opportunity to acknowledge the great care that's being given, but we also have an opportunity to look at the data and really focus in on sort of surveillance of a deeper dive into what's happening in communities where we don't always get a good sense of the data and what the trending treatment patterns look like. So I talked about Get With the Guidelines. I referred to it. Some of you raised your hands in the room that you might know what it is, but I just think it's important to kind of ground us in that as we go through this. So The Get With the Guidelines and quality improvement programs that I have the opportunity to lead for AHA is a series of inpatient registries. So we have a stroke module, I was just talking to someone about AFib, we have an AFib module, we have the heart failure, coronary artery disease, and resuscitation. And so they are intensive quality improvement programs. I always say they're not really registries, they're a quality improvement program that sort of, doubles as a registry. Because the point that we created these programs about 22 years ago when we started creating the Get With the Guidelines initiative, it was to fulfill the conundrum that we were in, that physicians, if you gave them a test on did they know the guideline, did they know what to do, they'd get an A+, right? They knew exactly what to do. But then when you abstracted 30 records and you looked at their practice patterns, they were like D+, C-, and we couldn't figure out how do we help translate into real world practice what we knew they knew in theory and on paper. And the first thing they said is, any of you hear this? That data's wrong, it's old, my patients are sicker. You hear all of those things, right? When they looked at the data and they realized that their data wasn't matching their knowledge level, they didn't quite want to accept that. So we started down this path to say, well, what gets measured gets done, right? So how can we show them the data, show them their practice patterns so that they can then improve? Where we had big best practices, where we had successful sites, we could then use them and take this channel that we've created across the country and disseminate that. And we've been able to do that very successfully with with stroke and certainly with STEMI care as well. And we're now doing it with heart failure in a very big way. And so we have some great successes that we can share from best practice sharing and QI consultation. And I keep pointing over here because I have staff that are sitting here that are actually the dynamic duo that will be leading this program in the rural space for all of you as we move forward. But this opportunity to take the data and create these learning collaboratives where everyone learns, everyone teaches, and we were able to see numbers rise dramatically. In 2 years' time, we've improved heart failure care and by 20% in the sites that have been working with us in a heart failure initiative. We know that we've improved door to needle time and ischemic stroke care dramatically over the last 15 years. I mean, we have taken what would have taken twice that time, and we've reduced door-to-needle times, and we've really sort of changed the trajectory of care in the U.S. Not we, the Heart Association, we collectively working with all of the hospitals that were in our programs. But in any event, we have 50% of the hospitals in the nation are utilizing our Get With the Guidelines programs, one or more of the modules that I mentioned. And then we have about 11 million patient records. So it's a robust data set where you can look at your data combined with compared to like facilities, to national averages, to geographic benchmarks. So we have this opportunity to, based on who you are, what your hospital profile looks like, you can compare and look at that. So you're not just looking at how well you're doing or how poorly you're doing, but how you're doing compared to others. So those numbers mean something and it's in context, right? So we have that going as part of this program. And that we know that in the stroke space, we arguably, I had a volunteer who once said, Dr. Lee Schwam said to me, arguably the American Heart Association's Get With the Guidelines stroke program is the largest stroke registry in the world. We have 90% of all ischemic, the hospitals that discharge 90% of the ischemic strokes in this country are participating in that registry. So we have the data, we know what to look for, and we use that data to create our educational materials, and we also know that when applied, there's been about 650, I think this says 600, but it's been updated. It's about 650 peer-reviewed, top-tier journal research articles. Again, I could have shared all that statistics with you, but I'd rather you read that, and at another time, if you need it, we can send you the links to those articles. And about 70 of them have documented disparity, reduction or elimination in disparities in care. So ethnic, gender, race, we've been able to eliminate disparities in care when the framework's applied and it works fast and it's sustained over time. And it's a plethora of resources. It's not just about entering data and looking at the data. It's about quality improvement efforts and consultation for your facilities. The other thing is that we know that about 80% of the US population is within like 20 minutes of a Get With the Guidelines facility. Now, what we didn't do was dive into the rural numbers, and that's something we need to look at and see, because I have a feeling that number will be, certainly different. But we're here to make sure we can fix that. And then we also have some outpatient initiatives where we're looking at, as I talked about, hypertension control, cholesterol, and type 2 diabetes programs. So as I move forward here. So I'm not going to spend a lot of time on this slide, but it really is just sharing with you sort of our footprint in this space of quality improvement for cardiovascular disease, inpatient, outpatient. So a lot of times I hear from other partners, they say, well, how do you get these hospitals to do this work for you? How do you get them engaged? Are you paying them? No, we're not paying them. Well, how do they get involved, and why? Why do they want to do it? And so when I think about the why, there's multiple reasons why. And we'll get into them in a second. I just kind of wanted to show this because really what this shows is, we are trying to be hitting the patient where they are and across the continuum of care. So we have solutions in all of those areas that we can partner and work with you on as part of this rural initiative that we're talking about here. We know that consistent care is key. We know that, I talked a little bit about the benchmarking and guidelines-directed medical therapies, and we look at composite scores, we look at defect-free scores, and then we look at individual metrics. Are the patients getting the right medication when they're discharged? And then 30 days later, are those patients still on the medications, et cetera? So this is a really, important piece of, we track social determinants data as well. So we'll talk about that in a second. This is the slide that talks about how, we've been able to reduce disparities in care. And we're also working very closely to create a research network for sort of the unusual suspects, right? Because the usual suspects are all in the clinical trials. They're all where where industry goes to find their patients to be enrolled in trials. And that's what's causing lack of diversity across the country in these trials. So we want to work with facilities that aren't normally in trials, don't think they could ever be part of something like that, and help get them up and ready to go. And so we are seeing some success in that. And we've actually been working with more community hospitals and smaller hospitals to say, you can do this too, we'll help you, and walking them through how to set up and be part of a network. If you look at, this is the data I've talked about. I said I wouldn't share much data, but this is one of the areas where we can see that over time we saw differences in care by race for defect-free measures. And so over time, we start to see comparable treatment, which is what we want to see, certainly across the country. So when we think back to the AHA's, commitments to health equity, a big one is certainly the right patient getting the right care, right? And so here's how we've been able to prove that the work that we're doing is achieving that. Now, when we move into social determinants, it's really been an exciting opportunity for us because we were a little bit ahead of the curve. So as we've been hearing about structural racism, health equity issues, disparities in care, we were already developing these types of questions to be added to our registries because we knew that our volunteers sort of see around corners, and we're saying we should have been looking at this sooner. So how can we add this data in? So within our registries, you can track unmet social needs and for your stroke and heart patients and start to see some interesting data and trends. And now this data repository is leading to more research, which we know will then help us update our guidelines and hopefully change practice patterns. So this is a simple, a field that we screenshotted and pulled out of the tool, but really important that we felt you would be helpful to see. And certainly as we think about where we need to be, I'll just leave the heat map here for you to look at, but we've really dove into where should we be doing this program, because normally we charge a nominal fee to participate, but we're even waiving that. In addition to the nearly $4 million investment AHA is making, on top of that, we are waiving the fees for participation in Get With the Guidelines for a subset of rural hospitals across the country. So excited to talk about that. But when we talked back about the accelerator, so the project is called the Rural Healthcare Outcomes Accelerator. And it really is about how we can expand care across the country. This is the website. You can go out there and Google Rural Healthcare Outcomes Accelerator, and I'm sure there's a way that we can disseminate this information out to all of you. But there's, there was a press release done, and again, we just really we were so excited to sort of unveil it here. We sent the press release out, but this is really the first time we've had the opportunity to talk about this in a detailed way. Here's what the eligibility looks like and what we're looking for hospitals, to participate in the program. We went through and we really started to look at, it's for any one of the, a new contract for any new module of Get With The Guidelines, you would be receiving that for at least the first 3 years would be no cost to you. You would be getting the QI consultation, the webinars, I'll get into the details of what else you would get, but this is really roughly what it looks like from the demographics and the size of the facilities. This is all can be found through, if you go through that website, and we will reach out to hospitals to participate. We focused in on, we looked at RUCA codes, and we really dove into the data, and I'll tell you something I learned. Let me go back to that slide. Something I learned even when we were doing this, now I'm really all messed up here. How do I go back? Bellas? There you go. Okay. So one of the things we learned as we looked at the data, and I said, how many can we do? How much of this can we cover across the country? And Mindy and the team were looking at the data, and we started to see, it was an aha moment for me. We're looking at all the numbers, and there's a bunch of zeros. I'm like, well, they don't discharge any. She's like, of course they don't, because they're transferring. It's like the dull moment. I had a aha moment. Where I was like, oh yeah, that's right. So how do we look at that data for those facilities that aren't actually admitting these patients, and how do we dive in? Because they are part of the process, right? They are part of the chain. So it was, I'll admit that was a learning for me. But, so when we think, this is just to say we're on here. So if you really wanted to Google, you could look this up, and we're listed on this the information hub. So excited that we made the cut there. This just shows where across the country where our contracts are, where activating facilities are participating with our programs. Okay, so when we think about the participant benefits, I started to get into them. A couple of them I want to talk about. It's, again, no cost to be in the program. You get a QI one-on-one precision, I call it precision QI consulting. They're looking at your hospital because we know, you've seen one hospital, right? They're all different. They all have different challenges. As I said, geographic, human resources, financial resources and constraints. So we want to make sure that we're working with. There are certainly things that are standardized across our core success factors, but we know that everybody has their unique challenges. We also will be offering lifelong learning, so free access to materials that we normally, charge facilities for, charge professionals for. We would not be charging as part of this program. And we're even, we think it's so critically important to get your voices heard within our scientific community that we're offering some professional memberships at no cost as well, because we need you at the table. We need your clinicians at the table so that we can have a larger, stronger voice within the scientific community of the Heart Association. And again, you would be in a dedicated rural network and in a special recognition program. So we have this opportunity to, look at facilities across the country. Get With The Guidelines sites love to be involved with us for a couple of reasons. One, they love an Olympic style medal, right? We do bronze, silver, gold. They love them. Everyone loves medals. Everyone loves to be able to, I've seen them on billboards. I've seen them at train stops. I've actually seen a banner hanging off of the side of a parking garage at a hospital when I was driving to an event on a weekend, and I was taking pictures, of it to send to my staff, because we've seen the recognition of being in a Get With The Guidelines program, being a gold hospital or a silver hospital. Sites love that. The other thing that we do with our facilities around recognition that they love, if you're we're trying to get involved more in pay for performance, certainly. So we are part of the BPCI, a bundled payment initiative for facilities that are eligible for that. They can participate and get with the guidelines and get credit through a bundled payment initiative with CMS. We do public reporting, so it's optional, of course, but sites can use that. Some of the larger sites will use that for transparency credits to be in US News and World Report rankings. And so we're trying our best to leverage so that you're not just having to participate in this, but you get some added benefits. There's some great marketing tools that we have available. And as sites join this program, they'll be getting press releases and opportunities to sort of yell it from the mountaintops that they're part of this national initiative with us. So again, a little bit more on the details of the program. I know you're all saying, okay, Michele, this sounds all good, but what's it gonna take? How much time, right? So we started to look at, there's some different ways of doing it. We can do a CSV upload, we can do direct data entry, and certainly there are people that use, sites that use third-party vendors to pull that, to abstract the data on their behalf. Here's the direct time commitment for direct entry. So don't let those numbers scare you, because when you're thinking volume, think about, the volume isn't great, so the time commitment isn't as great as maybe, a larger facility, but it's still there. And we need to recognize it because we know how tight resources are for your facilities. So if the only barrier that's keeping you from wanting to be part of something like this is data abstraction time, please let us know, because we have some other ideas, creative ways that we've been able to work with sites to make that and remove the barrier. Again, the idea is to remove the barriers to good, quality of care and access, and we don't want this to be the reason why a facility doesn't participate, certainly. We talked a lot about this. I'm not gonna, spend any more time on it, but just some of the things that you get as being part of the program. But here's the best part. So, having been doing this quality work for 2 decades now, one of the biggest things we had was the as I said, Olympic-style medals. But none of the rural facilities, the smaller facilities, could ever get there. They couldn't get to an Olympics medal. They couldn't get to bronze because volumes were always the issue, right? We created this bar, which was where the bar should have been, but we didn't think about an equitable bar for facilities that couldn't ever hit that or achieve that. And as part of this, I've been banging this drum for quite some time, years, I'll say years, and finally got, when the presidential paper came out, the advisory on rural health, it opened the door for us to go back to our leadership and our volunteers and say, we need a different measuring stick. So this is great for big facilities, but what about our smaller hospitals? They're doing great work. They're giving the right care. How do we get them to an award? How do we get them to be recognized? And the scientific group went back, and my team went back, and they put their heads together, and they came up with an alternative criteria. I'll say equitable criteria, because someone said, oh, well, what, did you just lower the bar? No, we didn't lower the bar. It's a different bar. It's not that we lowered any standard. It's a different standard based upon the capabilities, the volumes, and the key things that these sites can deliver in care that's still quality of care, to recognize all the hard work that all of you are doing at your facilities and with your staff. So with that, excited to say that, stroke was the first one that we did, and we have now new stroke award measures that are specific for smaller facilities, rural hospitals. And I'm not gonna go into all the details on the slide, but just want you to know that we've created a different recognition program as part of this, because that we've heard a lot was, well, I can be in it, but I can't ever get past participating, and we do all this hard work, and we wanna be recognized. Well, now we've removed that barrier by creating this alternative recognition program. Equal, equitable, alternative, but it isn't lower. And then we did the same for STEMI care and certainly and STEMI care. And so really, have a great opportunity within that space, and certainly now with heart failure, created a standard around that as well. So really excited to have the opportunity to share all of that with you. So how can you, again, I'll end with where I sort of, hold on. There. There's the website, if you are interested or you want to be part of it. And we're really excited to have been here today. Partnering with NRHA is so exciting to have this opportunity to, when they told me how much time I was going to have to speak, I thought, can I fill that amount of time? And apparently I can, I think. But it's just really exciting. And I would like to open up for any questions. I don't know how the mics are going to work, but if anyone has any questions, or if there are any questions online, I don't know who was supposed to. Where's Donna? Okay.
Any questions? Oh, we have one over here.
Of course.
Thank you, and you belong there. It was a privilege to break bread with you. I spared everyone the story about the 5 miles up the hill I walked to school and back, but that was my father's story. First, I appreciate your story. I lost a grandfather, 2 uncles to stroke and heart disease, and my father as well, farm family in Minnesota. So I'm so glad that you're talking about this and the focus is on rural. I wonder if you have any projections, and if I missed them, I apologize. We're hearing about younger people now with colon cancer and so forth. Is there any body of work and data that can tell us about younger people in heart disease, and in rural communities in particular? And then I wonder if there's some other things that you can talk about with respect to kind of the converging crisis of closing hospitals, workforce shortages, and then adding the factor of increasing amounts of cardiovascular disease, and if that's some data that you might have.
Yeah, so with respect to the trends on younger, I'll try to remember your multiple question there, but the first part, with respect to the trending younger for heart disease, we have invested in quite a few strategically funded research networks that are diving into that right now. So I expect that we're going to have a lot more data around that. I also expect, not to bring COVID up again, but I expect that we're going to see part of that is due to some of the long COVID and the COVID that's happening within younger people. We are looking at a registry around cardiomyopathies and some of the related to myocarditis. So there's some new data coming out. I don't have any exact statistics today, but I think there's more coming quickly. And I know, our large meeting is Scientific Sessions in November, and there will be, from what I can tell, there's a firewall, so I don't get to see all that good stuff over there until it comes out. But I expect to see a lot of interesting data coming out in November. Yeah. The second part of your question was around, remind me. The colliding, yeah, the challenges, right? So when we look at workforce, certainly AHA is trying to do everything we can, even with respect to, that hardcore that we've created. I mean, it's $9 million investment. It's only 100 staff, so I mean, how far is that going to get us, right? But it's trying to address issues within communities, looking at training, trying to procure and work with other foundations out there to help us sort of stand up a workforce where there's shortages. And we are trying to work in that space. A lot of people scratch their head and say, why would the Heart Association do that? Well, we know it's a cascade, right? If you don't have the right staff, then people don't get the right care that they need. And if you don't have employed people that can afford good health care, their medication, and good, healthy, fresh, whole foods, then it's going to create an even, a bigger cascade of, again, more risk factor issues to deal with down the road. Did I hit them all?
Yeah, you did. Absolutely. Thank you. I think about the community paramedicine program and point of intervention. I was just saying, I think about the community medicine or community paramedicine program and how that is budding and how that might be, a way to do some interventions before.
Yeah, we actually tested that we did a program called Get With The Guidelines 360. It really was to create a surround sound around the heart failure patient and how paramedicine comes into play in that. And we tested that in, weren't quite rural areas, but certainly in St. Louis, we did Chicago, and we did Wisconsin. And so we started to look at paramedicine in the mix, and we had some great findings from that. And we actually highlighted them as in one of our quality showcases as a best practice. So paramedicine is definitely could be a key factor.
Any other questions? One over here.
I am just curious, is there a limited number of hospitals that are going to be able to participate? And if there is, how are you going to evaluate appropriateness? I come from the South, Louisiana, and we're quite grateful that Mississippi is around, because if it wasn't for Mississippi, we'd be at the bottom of every horrible statistic. So, and heart, I'm sorry. And I apologize to my Mississippi colleagues. But I was once in Mississippi, so I can, but anyway, so would there be any focus on some of that geographic area that the morbidity and mortality is so much worse in with regard to heart disease? The other thing I wanted to just comment on, because I thought it was fascinating, I was talking to a cardiology group, and they were telling me about some of the work that they were doing in, I'm probably going to say it wrong, but cardiac toxicity of certain drugs, and especially chemotherapy drugs, and how that because cancer is becoming more of a chronic disease, because we're figuring out how to treat it and live with it, we haven't studied quite, or we're starting to learn more about how chemotherapy's effects on the heart, and we might be curing a cancer, but we're shortening the life of the patient through the impact on the heart, which I thought was, I didn't even know.
Yeah, so I'll start with your last question, then go back to your first one. So with respect to your comments about the cardiac toxicity, we actually we have a lot of balls in the air at the Heart Association. I talked about the maternal fetal health, the rural health, the work that we're doing, we were doing around COVID. We're doing two other big diving into cardio-oncology, because we know that that's a huge issue, and we're hearing it loud and clear. So the maternal and fetal health, as well as cardio-oncology, are the two sort of big areas that we're getting into. And then the third one is the nexus of the cardio-renal metabolic patient, right, and how that all ties together, and looking at the kidney implications and the diabetes, and then certainly the cardiac issues. So they're sort of like what's our new frontier and where we're headed next. So thank you for reminding me to bring that up. And then your question about eligibility and is there a defined number? So the two big things, there's certainly, you're all like, what's the fine print, right? So what's it going to say? So there's not a lot of fine print. We want the engagement. We want to make the commitment. My personal goal is that when this program, it's never going to end, but in 3 years when the money that we have to cover this is gone, that we can maybe get to the point that we just are always free. It's always free for rural facilities to be in, because we know how important it is, and it's a mission imperative for us. We do things that certainly generate revenue, but we do things that are mission imperatives, and sometimes they don't, and that's okay. But from an eligibility standpoint, we looked at RUCA codes. We sort of prioritize where we think we would start and where we would end, but I don't anticipate us having a limit and setting a number. Anyone who's eligible and wants to be in, we are not going to turn them away. The only caveat is if you're in an existing, say you're in with the guidelines stroke, and you want to join, whatever new modules you join will be at no cost. We figured and did the math, we couldn't go back and sort of retroactively given the ones you already have at no cost, but anything new that you add would be covered, and we would not turn people away simply because we hit our number of 500 or 700, but we want that to be our problem, is having too many sites. Yes.
We got an online question.
Thank you. So the question is, as a rural CA, we oftentimes can care for the cardiac and stroke patient initially, but often the challenge is transferring the patient to an accepting tertiary hospital. One transport means and two, finding a hospital to accept in a reasonable time period. Any ideas or solutions?
So that's a great question. Mindy, I might put you on the spot to give your answers there if you were listening. So first, one of the things that's really important as we do this work, we try to encourage that hub and spoke model, right? Where you can have a relationship. Maybe they're outside your healthcare system. Maybe it's, but having and understanding the capabilities of the facilities around you and creating relationships. That's one of the benefits of, as we do the Mission Lifeline program, we bring together around the table, I always say AHA is like Switzerland, right? We bring people around the table that don't normally break bread or sit with each other because they're fierce competitors, right? And so they come around an AHA table. Sorry, I'm talking really fast and using my hands, I just realized. But It's a Philly thing. So when we bring people around a table, we can break down barriers between institutions that normally wouldn't want to work together. And so I think that's a differentiator of the Heart Association, that we add that to the list. And I would love for Mindy, would you introduce yourself and your title, and then you could answer?
Sure. Thanks, Michelle. So my title just changed. I haven't officially announced it anywhere yet, so I'll be happy to do that. I'm a Regional Director of Quality Improvement and Rural Programs for the American Heart Association at the National Center. I live in Minnesota, and I'm a rural country girl, so I'm super passionate and excited to be a part of this initiative and to help lead our team of 5 staff who will support this work across the country. But to that question about the challenges with interfacility transfer, I think it's a huge question. We get a lot, and we're really looking forward to, in this project, convening collaboratives to really identify those model practice strategies that could help others across the country. If some sites are doing that really well and have thought about creative solutions, I think there is no one-size-fits-all solution. It is really having a plan A, B, and C for when A and B fail in place, and having kind of those official relationships with EMS agencies in the area and outside of your area who might be able to come in and help when the local one is not available. So I think that is a huge issue that we want to address through the course of the project. I know we've added a few data elements into our collection to really get into the weeds, to address the barriers of those interfacility transfer issues that are coming up that are a little different than what we faced pre-COVID. So I think as we start collecting and really diving into that data and looking at it as a rural cohort, we'll be able to kind of fine-tune and share those strategies out to those who are participating in the initiative.
Any other questions? We have one back here.
I don't have a question, but I'm going to give you a shout out for your workplace well-being that I think sometimes we forget that the AHA has available. We worry about our patients, but we forget about ourselves and our employees, and that's such a great program where we can start setting the example. So kudos to you if you want to talk about that, just a short thing with your workplace well-being.
Yeah, I will I'll make one comment. Thank you. In addition to thank you. We have what's called Life Simple 7, and that's something that we work with facilities to workplaces to look at how their workforce, what's the score for, the aggregate, what does the individual score look like? And it's related to certainly the seven risk factors. And we just recently, and Mindy told me I should have put a slide in about this, and I didn't. So I told you so, Mindy. So there's, now we are Essential 8, Life's Essential 8, because they added sleep in as the 8th risk factor for cardiovascular disease, because it's something that the organization, our volunteers, felt like could be measured and tracked along the way. I don't want to measure my sleep because it would be scary. So, but yeah, I think we are very fortunate in engaging with, we have a whole other department that is called, Healthcare Business Solutions, and works with facilities and workplaces around workplace health. And having that's sort of the core of that program is our, what was Life Simple 7 is now Life's Essential 8.
Excellent. Any other questions? I will make a comment that Mindy and others from AHA will be at a booth in our lobby here for the remaining number of days for our conference. So please feel free to stop by and visit with them about this program and what it can do for your hospitals going forward, so in clinics. Any other questions? All right. Well, thank you very much.